Thanks for joining us. Dr. Monty Aghazadeh, urologist at Houston Methodist. I'm joined today by Dr. Brooks, Dr. Ekeruo, and we're here today to discuss our experience with the single port robotic platform and share our passion for this new technology and share how we've been using it. It's something that we're really excited about and something that has really changed our practices. And so we're eager to discuss this today. So I appreciate everyone joining us. Several things that we wanted to get through today, but I'll start with Dr. Brooks. Just give us a quick overview of what single port robotics is. What's the difference between the standard robotic surgery and what's new about it?
Well, traditionally, multi-port robotics was the first thing that came out about 20 years ago. And it revolutionized surgery because it allowed for better dexterity, magnified vision, and allowed for us to do procedures that would be technically very challenging using laparoscopic instruments alone. So the wristed motion allows for very detailed sewing and allows us to move through surgical procedures that were very, very challenging prior to that. So that multi-port robot has undergone multiple iterations, to the point where we got to 2019 when the single port robot first was FDA approved. All of those different iterations previously were all based on the same themes of multi-port robotics. And so the approaches to surgery really didn't change that much in that almost 20-year time span. But in 2019, with the advent of the single port robot, every instrument could travel through a single small incision, 25 millimeter incision, allowing us to do direct to organ surgery, to tackle new techniques in an extremely minimally invasive way that just wasn't possible before with multi-port surgery.
It certainly has changed the game, so to speak. And Dr. Ekeruo, if you could kind of tell us what the experience has been so far with the single port platform.
Right. So initially, when we adopted the technology, there were some challenges because it was a new approach, and operating with the multi-port platform was very straightforward, easy, and intuitive. And so we had to make a lot of adjustments in learning and adapting the single port technology to the procedures we did. I will say that going through the formal training was very helpful, and I will say that there was a learning curve. However, I think that we were able to overcome this learning curve because we operated together using the team-based approach. And I think we had to rethink how we approached laparoscopic and minimally invasive surgeries with the multi-port platform. I think one of the early stumbling blocks we had was that we tried to replicate what we were doing with the multi-port, with the single port, but we had to think about it a little different. We had to approach each organ in a targeted fashion and not try to replicate the procedures we were doing either laparoscopically or with the multi-port platform using the single port platform. And I think once we made that switch, we really began to excel at the procedures we were doing and begin to reap a lot of the benefits of the single port approach.
Yeah. No, there's no doubt. It was definitely a difference in terms of the techniques, the technology, the approach to surgery, and it's been interesting, right? We've had our platform, our single port platform, since 2023 or so, and in that time period, we've done around 500 cases. So to say we've embraced it wholeheartedly, I would say is an understatement. And I think, one of the things you talked about that's important to discuss is the learning curve. And what's been unique about our experience and our perception of that learning curve and how we've gotten over it is the team-based approach that we have at Methodist in terms of tackling some of these difficult surgeries. And that's one of those things where we're able to work together in pairs. I don't know if you want to talk a little bit about that, Dr. Brooks.
Yeah. So, about 5 or 6 different hospitals in Houston have adopted this technology in a relatively short time period, and not all have been able to embrace it and have the kind of success that I think that we have as a team. One of those the special thing about what we do is that we always have two expert robotic surgeons doing these technically challenging cases together. So where others typically work with either an untrained surgical tech or even a resident that has minimal familiarity with the system, we all learn together and work as a pilot and co-pilot, so to speak. And I think that's a great analogy. We're constantly bouncing ideas off each other. We're constantly learning from each other and really perfecting these procedures. So as far as our learning curve, although initially the procedures were taking longer than what we were typically expecting from a multi-port approach doing a similar procedure, we cut that down very quickly. And we always had good outcomes throughout the whole process because, again, we're there working with each other, making sure we're doing things safely, making sure that we're taking care of the patient and doing things in an efficient fashion.
And that team-based approach, it's not common in surgery, urology, surgery in general. Typically, there's a pilot, to continue that analogy, that is in charge of the ship, steering it, making sure everybody's in rowing in the same direction. So that's really unique that we have that, I think, team-based approach where there's often two of us in the operating room together, and we can do these procedures in tandem. And that really, I think there's multiple benefits to it, but I think, it helps with efficiency, patient safety, but really this, we're all well-trained. We have a lot of surgical experience between the three of us, but there are areas where each of us have our own expertise. And I think it's really nice and beneficial for the patients, because where each of us shine, all the patients get that. And so there's a cumulative surgical experience between the three of us that really gives our best version in terms of surgical efficiency and performance to each individual patient.
Absolutely, I totally agree. And I think working in tandem certainly helped us overcome the early challenges in overcoming the learning curve so quickly, and to be able to do as many cases as we've done, and to be able to accomplish this with really good outcomes and very little trouble, I have to say. So it's been a really positive experience.
Dr. Aghazadeh, do you want to speak on why we embarked on this endeavor? I mean, we obviously could have continued to do things the way we'd always done them.
I mean, the single port platform, certainly you hear about it, you're like, this is just the next generation of robot. Like you said, there's been several iterations. Initially when we heard about it, we're like, it's just the next one. We're going to adopt it because, we're always trying to try new techniques. But what we didn't realize was how revolutionary it was. This is something that has changed not only how we're doing the surgery, but how we're approaching it. And it's truly been practice changing. And so I would say that, the key difference is that with the multi-port system, typically organs, whether it's the kidney, the prostate, the bladder, we were approaching it transperitoneal. So going through the abdominal cavity. But this single port robot has allowed, because of its small incision and the instruments that come in through a cluster, it allows for what they've referred to as regionalization of surgery. So we've directly approached the organs of interest without going through the peritoneal cavity, without exposing other organs to potential risk or injury. And so it's something that has really changed how we think about surgery and how we're approaching it. It's been really one of those things that, in the past, when we were doing open surgery as urologists, we would always stay in the retroperitoneum. We would, make bigger incisions, but go directly to the organ. But with the advent of laparoscopy, robotics, we were spending all our time in the peritoneal cavity. And now it's a return to the retroperitoneum. And it's almost this full circle moment we're back where we belong in a sense.
Right. Yeah, I agree with that completely. The multi-port approach, while you could do retroneoscopic surgery, go directly into the retroperitoneum to access the kidney or access the adrenal gland, it was a bit of a challenge, Similarly, with going into the space of Retzius, staying outside of the abdominal cavity and the pelvis and accessing the prostate. Could it be done? Yes, it can be done. But this is like purpose built for that type of approach, and that's what allows us to be extremely efficient with this robot, where challenges space, ability to get all of the instruments in at the same time in the same small space was a challenge with multi-port. Now it's purpose built. It's direct to the organ, minimal incisions and minimal exposure.
Yeah. So Dr. Burks, you do a lot of oncology as well as general urology. Can you touch on some of the cases you've been able to perform with this platform and what kind of outcomes you've seen with it?
Right. So essentially I do 95% of my cases with this platform. I think like we just mentioned, prostate surgery, kidney surgery, adrenal surgery, it's purpose built for this. It allows for not only the retroneoscopic access, ease of access, but also, all of the benefits of robotic surgery. So detailed sewing, detailed, magnified vision, all of these things. So yes, we do radical prostatectomies. We do partial nephrectomies, complex partial nephrectomies, adrenalectomy, and we've even approached radical cystectomy using this platform, which also has benefits in terms of minimizing incisional pain, minimizing the pain that the patient experiences post-operatively.
And it just boggles, it's still hard to wrap my head around the fact that we're doing these really complex surgeries through these small holes, right? You could have never imagined this, 15 years ago, 10 years ago. It's just hard to believe we can get into these small spaces with this single port platform and do these complex, intricate procedures that require a lot of dexterity, precision, and we're doing it through these really small holes, and that's been really interesting to see.
But Dr. Aghazadeh, to take a step back, again, the motivation behind this, one of the things that I have always wanted to emphasize, and something I learned from one of my mentors when I initially had my initial experience with single port robotics, was we're not doing this just because it's a small incision. We're not doing this for cosmesis, although the cosmesis is excellent. We're doing this because it's a whole different approach to the surgery that we're doing. And that the recovery and the value added to the system after that. So if you can think about it, the transperitoneal surgery that we were doing, all of these patients have, to some degree, ileus. You have to move the bowel around. In this case, we're not even touching the bowel. We're nowhere near the bowel. So all of these patients, as soon as they get to their hospital room, they're on regular diet. Many of them have minimal pain, so they're up and walking right away. And can you talk about your experience with same-day discharges?
Yeah, and that's one of the major benefits of this is we're able to send a lot of patients home after these complex procedures, and we could have never imagined same-day discharge. These patients, were doing major procedures, and they're going to the PACU and they're going home, and it's really been interesting to see just how many patients and how many patients with relatively complex surgeries could potentially just go home, spend the night at home, be more comfortable. Certainly the patients appreciate that, the hospital appreciates that, and it's been one of the major boons of the single port platform, I would say.
Yeah, I mean, in addition, I think it's also expanded the range of patients we can offer this platform to in terms of as an option of how to approach their surgeries. We've had patients who've had hostile abdomens where you otherwise would not consider going through the belly to operate either on the kidney or the prostate, but because we use a retroperitoneal approach, we're able to offer them this platform, this technology. And I think we've also started offering the surgery as well to patients who are a lot older, octogenarians, because it's so minimally invasive and there's very little blood loss and recovery is very quick. These patients are able to tolerate the surgery and have really good outcomes.
Yeah. Yeah.
That is one thing that it's just undeniable. It's a category difference in terms of the recovery for these patients, and that's why we do it, right? One of the things that I feel like is a challenge for urologists in particular and surgeons in general maybe is that we're not with our patients when they're little Jimmy 5-year-old and you're his family medicine doc with him all through his whole life, basically until he retires. We get to meet our patients and develop rapport in 1 or 2 patient visits before we move forward with surgery as surgical subspecialists. And so it's a short and condensed time period. Now, with this optimal recovery, minimal pain, these patients, develop trust very quickly in us. And so it's much easier to explain to a patient that feels good post-op, that's walking, that's eating regular food, that, hey, your surgery went just how we planned it. Everything went really well. It's the full patient experience that improves with it.
And I think, it's worth touching on some of these patients where, they've been complex, or in prior generations, I should say, they would have been complex, but they've come to us, we've used the single port platform, and it's been a very relatively straightforward procedure. Do y'all have any examples of those where it's changed the complexity of the procedure?
I would say one that comes to mind is a gentleman that I saw not too long ago, really hostile abdomen. He was in an MVA many years ago, was ex-lapped. And, the gentleman needed a radical prostatectomy for prostate cancer. Now, because his belly had been lapped, obviously it wouldn't have been amenable to the multi-port approach because he's going to have a lot of adhesions, risk bowel injury, and so on. By being able to do an intravesical radical prostatectomy from a suprapubic approach, you're able to accomplish that, right? And so that's something that is unique. And I think not too many people are doing around the country in terms of the intravesical approach to doing a radical prostatectomy. Yeah. And so being able to offer him that and, address his cancer is, very meaningful. And otherwise, he wouldn't have been able to have surgery for this.
So in my experience, similarly, patients that have had prior surgery, prior procedures, even I had a young woman that had a colostomy for colon cancer at a very young age and had a large renal mass on the same side as her colostomy. Her colostomy couldn't be reversed. So it was important to make sure that we stayed away from it and took care of the cancer in appropriate surgical fashion, and going retroperitoneal, removing the kidney. She's done excellent.
Yeah. I mean, these cases, for example, they would have been, challenging, maybe even impossible in prior generations, or prior technology available. And now they've become something that's just, it's a straightforward, simple, even procedure. And it's interesting how this technology has allowed for us to do that. In the past, in terms of our checklist for patients getting their history, one of the questions we always asked was, have you had prior abdominal surgery? We still ask it, of course, but now it doesn't really matter as much because we're not entering the abdominal cavity, and the risks and the challenges that adhesions from prior surgeries, it's just not what it was. So it's really interesting.
Dr. Aghazadeh, can you speak specifically? We've been talking a lot about cancer and approaches to prostate, kidney, bladder for surgical procedures with oncologic purposes. Can you speak specifically about your experience with benign disease, benign prostatic hyperplasia specifically?
Yeah, so several benign conditions that we tackle with this, but one of our favorites, I think, and ultimately this is because of patient outcomes, one of our favorites is the transvesical simple prostatectomy. So, of course, for BPH, for difficulties urinating, retention, big prostates, small prostates, this is something where we're able to get in and out, go through the bladder, remove the enlarged portion of the prostate, and get, patients urinating, improve quality of life, improve, get them catheter free. And that's been one of those things that's, in the past with simple prostatectomy, it was a major operation, really bloody. It could be, a really a big challenge when it came to open simple prostatectomy, and that certainly evolved as we moved to multi-port robotics, and it became a safer procedure, more elegant procedure, safer procedure, but still patients required, continuous bladder irrigation and an overnight hospital stay. And now with the single port robotics, it's really unbelievable, right? These patients are coming in, we're doing the simple prostatectomy, doing, a reconstruction afterwards. And the vast majority of these patients are going home same day with a catheter, but without CBI. And that's one of those things you just could have never fathomed before. They hear simple prostatectomy, you hear about it, the mind immediately jumps to a bloody surgery with catheters, drains, prolonged hospital stay, and that's just not the case anymore. And you had mentioned surgical candidacy, and this certainly has changed who is a candidate for simple prostatectomy because of the decreased risk profile of this surgery. I mean, doing older patients, we're not only applying this to patients with bigger prostates, which was traditionally the case for simple prostatectomy, and that was totally due to the risk associated with the procedure. But now we're doing smaller prostates because we know that they do well, and it's the safety profile is excellent, and these patients, I have to say, they're really our happiest patients, right? These are patients that,
Right.
Oftentimes we do the procedure and, they come back for their post-op follow-up and then we never see them again because they're fine, right? And I can't tell you with other types of, urologic procedures for BPH. I mean, they're coming back and, it's good for a few years and then the symptoms slowly recur. And then you're thinking about medications and different surgeries and different options. But these patients, oftentimes we just, see them for their post-op and then, don't see them because they're fine.
Do you have any limits in terms of gland size when you approach patients with BPH using this technology?
Yeah, that's ever evolving. Initially we were trying to, keep it under 200 grams because, there were some differences in technique and how we approach these procedures. But now we're starting to do bigger and bigger prostates because we've learned, again, it goes back to our approach to the single port robot in general. We're not doing the same procedure. It's different. So we're approaching these cases differently. There's different techniques. There's different ways of doing it. So it's not, the standard simple prostatectomy. There's an evolution of technique that has allowed us to tackle bigger and bigger prostates. So we talked a little bit about benign conditions. What about oncologic conditions? Where do you see there's a huge value in terms of the single port platform?
Well, I think that doing multi-quadrant surgery is a unique thing to this. So when we think about like a nephroureterectomy, a patient that has a urothelial carcinoma involving the upper tract, we remove the entire kidney, the entire ureter. Well, that spans the whole retroperitoneum, both the lower quadrant and the upper quadrant. That used to be a challenge to tackle with a single dock on a multi-port platform. Now, the way that this platform is designed, you can pivot from one area to an entirely different area of the body, which is unique. And it allows us to get great vision, great exposure, both of the kidney and the retroperitoneum, but also lower into the pelvis. And we've had a lot of success doing these procedures and allows us to even do them extraperitoneal as well. Dr. Aghazadeh, you mentioned specifically, some of the BPH, advances that you've made. Can you speak specifically about the quality of life changes that you've seen in some of your patients, specifically patients that were catheter dependent coming into the procedure, and how you think about them differently and how you approach the surgery and what you've experienced in terms of their outcomes.
Yeah, and I think specifically it's certainly patients that have gone to the emergency room, they've gotten a catheter placed, acute urinary retention. That's certainly something that we can address in this fashion. But the really interesting part of this is patients that have been on catheters for years, right? We've had our fair share of patients that have been catheter dependent for a prolonged period of time. They've done studies which have shown questionable bladder function. And with these procedures, we're removing the entire adenoma, we're completely enucleating the prostate, and it's been awesome to see that, over 90%, 95% of these patients are urinating on their own afterwards. When we were potentially in a position where, in the past they were too sick to have a surgery, or their bladder didn't work well enough, or there was, other potential reasons why they weren't surgical candidates. But this has been really, I don't want to say a godsend, but it's been wonderful to be able to offer this and to see a patient in clinic that in the past you would have said, I don't think that's anything, I don't think there's any surgical option for you. You just have to keep this catheter. You have to, change it every month and deal with the UTIs and the intermittent hematuria that comes with it. Now we can confidently say, yes, we can fix this, and we feel really good about being able to keep you catheter free for the rest of your life. And you can't put a price on that, right? That's been really awesome to see.
Yeah. So in developing a lot of the techniques that you use to approach patients with BPH, we know you had a presentation at the AUA addressing a novel technique to dock the robot within the bladder when you're doing this intravesical simple prostatectomy. Walk us through a little bit how you came up with that technique, and what impact have you noticed it having on achieving the procedure successfully?
Yeah, so this video was about what one of my mentors coined as dock stacking. So this is something that we innovated together, of course, during these procedures. And what we saw was, when we go transvesical, right, you go in there with the robot, but we were closing the hole in the bladder open. So we were doing open cystography, which honestly, even with the multiport platform, we weren't doing that. And so it had been years. I can't remember the last time I was doing open cystographies. And it was a very foreign thing. And of course we could do it, right? But we got this very expensive robot, and we're doing open surgery to close the bladder. And that didn't feel right to me. So what we did was stack our docks. So we would have 2 wound retractors to be able to access in the intravesical space and the extravesical space. And certainly the video does a better job explaining it and going through what this actually entails, but it just allows us to utilize the robot both in the intravesical space and the extravesical space without having to do open surgery. And that not only applies to simple prostatectomies, but also radical prostatectomies, where we're going transvesical, removing the prostate, and then coming to the extravesical space to do our lymph node dissection. And again, this allows for a seamless transition between those 2 spaces without having to struggle with introducing a new wound retractor and redocking and all those things. So yeah, that's been, it has been really fun, because, there was a period of stagnation when it came to robotic surgery. Right? We were doing the same thing over and over and over for 15 years. And certainly, there's value in that, right? The repetitive process and becoming, good at what we do. But boy, it's been fun to see this new technology and use it in ways that we're innovating and creating and evolving and being the first to do these procedures. I'd say one of the coolest parts, I think Dr. Brooks did the first single port radical cystectomy in Houston, and we've done single port transvesical radical prostatectomies and leading the charge on that, and so it's fun being ahead of the curve, and more importantly, rewarding as it pertains to the patient outcomes.
As it pertains to patient outcomes, can you please, just tell us what your experience has been? Have there been any major, issues in terms of complications or in terms of, having to convert to other techniques in our 500 case experience?
Yeah. So, certainly, as Dr. Ekeruo stated, there was challenges along the line, but there hasn't been a case where we had to convert to a different approach. We were able to, continue and accomplish and do what we set out to do. And in terms of outcomes, I think it's about, we're collecting our data, but 50 to 60% of patients on the whole of that 500 are going home within 24 hours. And that's all procedures, right? Not just, prostate or kidney. And then pain scores have dramatically decreased. In terms of the morphine equivalents or pain requirements, those numbers have gone down. But it has been really impressive. We used to joke at the very beginning, right? It was hard on us to do the surgery, but easy on the patient, right? Because we were adopting a new technology and it was challenging. There was a cognitive load to trying to do these new procedures and figure out the best ways. But despite that, right, every single time the patient wakes up, right, they look good, right? And that's one of those things that's just hard to put into numbers, put into statistics, is how that patient looks afterwards. And that's really one of the things that keeps us going.
Dr. Ekeruo, can you talk a little bit about the value added to the system by doing these approaches with the single port robot? Sure, length of stay is great, pain scores are decreased, but what else have you noticed?
I mean, I would say one of the main things is being able to operate on the single port platform. If nothing else, it frees up the multi-port machine for other surgeons who need to use it. There's more efficiency in the operating room. And because a lot of these patients go home the same day, or the next day, the patients are not staying in the hospital and taking up a hospital bed. And so overall, I think it's a benefit to the patient, but also a huge benefit to the hospital as a system.
Dr. Aghazadeh, can you talk to how we're using our own learned experience with this platform to benefit others outside of our hospital, outside of our system?
Yeah, so that's been really fun. This is obviously something that we're passionate about, right? We've adopted it and we've embraced it head on, and we've really been impressed with all the aspects that we've discussed. And so, because of that passion, right? We've become proctors for the system, and we're proctoring other surgeons when they adopt it. We're trying to help decrease their learning curve by giving them tips and tricks and trying to help them avoid some of the pitfalls that we experienced early on. And that's certainly been rewarding, right? You've gone to several institutions, both in state and regionally, it's really rewarding to try to pass that on. The other thing we're doing is having other surgeons come to our site, both in person and remotely, to observe the surgeries. And that's been really interesting. It's one of those things where, you're operating and teaching at the same time. And you really have to know what you're doing and why you're doing it and be able to explain it. And that adds another level of understanding. And it really solidifies our practices, I think. So that's been rewarding as well.
It's one thing to talk about it like we're doing right now, but it's a whole nother opportunity to show it.
Right.
And these surgeons have appreciated seeing what we're doing, how we use our team-based approach, how we're approaching these surgeries differently. And it's great to see other programs launch based on what our experience has been.
Yeah. And Dr. Ekeruo, I know with our experience with the residents and giving them experience and exposure to the single port platform. That's been really exciting as well. What's your take on that?
No, it's been fantastic working with the residents. One thing some feedback we've gotten from them is when they work on the multi-port platform, when they work on the single port platform, when they come back to the multi-port platform, it seems a whole lot easier, right? And then as they graduate and get a little bit more senior in their residency and they got more experience with the single port platform, they've pretty much universally really like it and enjoy the benefits that it provides. And it's been a real positive experience all around.
Yeah, it's really nice just to have, this is certainly something that we're, using very frequently in the majority of our cases, but there still is, certain scenarios where we use the multi-port robot, and part of the process has been figuring out when and where and in which cases we should use the multi-port system versus a single port system. And certainly that's been evolving over time, but it's also interesting to see it from the resident's perspective, from that fresh set of eyes, because they're learning both at the same time, right?
Exactly.
We learned one, we became an expert, and then all of a sudden this, disruptor of sorts came on the scene, and now, the residents are kind of almost learning both at the same time, and it's interesting to see their perspective on it.
Exactly. So for a program that's thinking of adopting this technology, what advice would you give to make it as seamless as possible and to give them the best chance at success at adopting the technology?
Well, I think one of the things that you just hit on, Dr. Aghazadeh, was mastering the procedure from a multi-port perspective and then going and taking that experience to single port. While our residents are learning both in parallel, I think it's important at this stage of the technology, for the surgeon to be a master at doing that procedure on a multi-port platform before they try to adopt the single port platform. Now, that may not always be the case, but this is the case at least where we are right now. In addition to that, choosing the right patient selection initially was a huge aspect of our success, right? So patient selection, you're going to choose a patient that the procedure is going to be relatively straightforward. You're not going to dive into the deep end with the most challenging case in your first 5 or even 10 cases. You need to get some familiarity with the platform under your belt so that you can get that cognitive load down of the muscle memory of how to operate with the instruments, how to move, how to achieve the goals that you want to achieve for each step of the procedure. So once that cognitive burden comes down, now you move on to the next more challenging case. This is how we always have done surgery, right? This is how we've always adopted new technologies. And this is how we do things safely. And every patient's outcome is important, whether it's the first patient in your learning curve or it's the 500th in our series. So that's how we approached it.
Absolutely. Definitely something that we're really passionate about. We want to wave the flag. We want to represent all the innovation and our ability to lead medicine at Houston Methodist. And again, thanks for joining us.